And I'll start with a little introduction and we'll use our time wisely. If more people come, we'll greet them excitedly. Welcome. My name is Aaron Scher. I'm the future CEO of NoTube, and next to me is my mother and medical director of NoTube, Marguerite Danitz-Schier. And today we will talk to you about our telemedical approach at NoTube for child weaning. We have received some questions preliminarily, but so that everyone's on the same page, I thought we'd start with a question that we do here, and then we'll have time for your also individual question. And this meeting will be recorded so that there is a webinar recording that you will then be sent when you were here. And we'll take the time we need, max 21:20. And once again, sorry for the technical difficulties. Mom, what is the difference between telemedical therapy of early children's food development disorders and non-telemedical or in person?
Okay, hi, good evening. I'm Marguerite. I've been really passionately interested in the development of healthy and not so fortunately healthy children in all of my pediatric career, which is now about 45 years, that I'm kind of obsessed nearly with this challenge. And it really also, when I became myself mother, I had 6 children, and amazingly enough, none of them had any kind of trouble, but it always gave me the opportunity to kind of, apart from the sick children I was presented with, to kind of always have the kind of normal development as a kind of model line where we want to go to. And since I worked for many, many years before tele was invented, before everybody had cameras, and we actually were making videos in the early 85 to 90s, early 90s, with a video camera about 10 kilos on our shoulders, which was at that time still a pretty threatening instrument for the children. Things have changed greatly. I personally believe that the future of most of medicine is actually in telemedicine. And the main difference, and this is really important for children and probably crucially important for small children, is that when you do traditional meetings of the child being taken to the doctor, the child visits the doctor in the doctor's environment. And these are hospitals, and they smell a little queer, and some children have traumatic memories to the hospital, and it's a white room, and there's a lot of technical equipment. And this visit of the young child coming to my home, let's say my work home, affects the child itself. The younger it is, the more. If you have a 15-year-old, it'll not be so strong. But a 3-year-old, 2-year-old, 1-year-old will get the whole atmospheric change of where it comes from in the full load when it visits a doctor in the hospital. Is this easy to understand? Now, the telemedicine is exactly the opposite. With the telemedical, I call it train, I visit the child in its home. I'm suddenly in the kitchen with the child, in its living room, in its playroom, and I'm seeing so much information which I never ever dreamt as a doctor to even ask about. For instance, the siblings, the environment. Children have dogs at home. Once I got a video, and the child had 2 enormous dogs, 4 times as big as the child, and the child kind of never could quite reach for its food because the dogs were there before. And I never in my whole life would have dreamt asking a family who comes to me with a eating problem, do you happen to have dogs? So this turning around of who visits who really is beneficial for understanding the complexity of what interferes or what might interfere with the eating problem. Because what we get as a pediatrician, and this is our daily life, is we are always meeting at least two patients, I call it now, at least two. The mom, who is verbally communicating with us, and the child, who normally is a little shy or anxious or not yet talking and is also there. And in this context, the environmental atmosphere is so crucial, because you will in the hospital meet a different child as in its own home, with its sibling, with its dog running around, the parents, and so on. So telemedicine really is much more than not being there physically. And I think in our world today, as people in the last 20 years have become not only familiar with the tele idea, but it's our daily life. I really have become very appreciative to use this option in the daily work with these children, who usually have really spent also too much time in hospitals, especially in the weaning group. And what I maybe would like to present to you just before we start discussing, to avoid confusions, the word net coaching was invented by me and the team specifically for helping tube-fed children, be this nasogastric tube-fed or PEG tube-fed or jejunal tube-fed. So the net coaching is the online tube weaning program of NoTube versus the Learn to Eat program, which is the online program for not tube-related problems like picky eaters, autistic spectrum children with eating problems. We then additionally also have an anorexia program, specially online. And that's why I just want you to know that the word net coaching in our understanding is specific for the tube children. And I don't know whether all of you now have a tube child, but if not, we can easily also talk about telemedical approaches of NoTube and programs for the non-tube children. Just to
Yeah. What I want to add is the one thing that you only slipped in as a side comment is especially the children on a tube that come to us. They have made too many experiences in their short life that were potentially traumatic in the hospital. And we have also arranged our eating campus here in Graz to be as little looking like a hospital as it possibly can, while still being a hospital and checking those marks. However, still the kids, and they can be 1 to 2 years old, they know so much better. They know a doctor, they know the situation of mother sits down next to me and talks to grown-up person, concerned voice, so well that for these kids we see for the first week sometimes, they really need to come down to believe that this is not a scary setting where somebody will do something potentially against their will. And so there, I think the telemedical approach really takes down a huge barrier where the kid doesn't even have to do the potentially egregious way to the hospital, because every time it has gone that way, it went home later or with some type of pain. So we really also take very serious this moment of, could there have been some medical trauma that plays a role here? And then, Mom, before we start the discussion, for the person who doesn't know, we all have a good idea of what happens in a life setting. I take my sick child to the doctor, they give me stuff, I go home. How does it work, if you want, online? Is it different to a classic therapeutic process?
Yes, well, I think it's like maybe taking a ride on a train. You first have to decide where you want to go from A to B. Then you have to somehow get a ticket, which we call assessment and free evaluation. Free evaluation is a chance to meet us without paying a single dollar yet or euro. It's a 20-minute interview where you can kind of check out, are you going to be able basically to help me and my child, or am I completely in the wrong setting? And after the assessment, which is then evaluated by two pediatricians, experienced ones, we define your child as suitable for the goal you have told us would be your intention. And then we call it the ticket opens. Then you kind of get a ticket, and then in a non-synchronous way, we start communicating by writing, by sharing videos, by answering a questionnaire. And the first half week of this process is used to get to know each other. So as a pediatrician, we are always three in a team in the net coaching. It's the pediatrician, a psychologist, and a what we call feeding therapist, which is an occupational or a physio. We ask you questions which we have not yet understood clearly enough from the questionnaire, and we kind of get the details. And I would say we get the bigger picture as clear as I need to start working, in the sense a doctor has to work. He needs a diagnosis, and we need a goal, and we need a treatment plan. And before I can apply my treatment plan, I must be really sure that I understand the problem. That's crucial. And this first week gives us, we make a Zoom, and we even can Zoom by letting your medical team join in if it's a medical complicated problem, or a child with a kidney issue or a cardiac issue. And after really mutually being sure that we think we are all going to travel from A to B together, then we start the actual therapeutic part of the net coaching process.
How does that look?
That's a daily, mostly twice, communication. The mums or dads write whenever they have time. It's mostly the evening. And since we have patients all over the globe, we have probably numerically more people who live in the time zone of Europe, but we have a lot of people also who are in America, Australia. So our team is set up to give a 24-hour coverage. If it's an emergency, child starts having a big fever or has a seizure, or it's a real emergency, we have an internal SOS line. And then we doctors are immediately communicated, child has a problem, and then we come immediately. But normally it takes between 2 and 4, maybe 6 hours for you to get the answer. And then you ask the next question, and then the next round. So we do 3 rounds in 24 hours, 365 days a year, including all festivities. And so this is a very, very, very close and supportive. I think the parents really feel that they can ask on Sunday night and they'll get an answer still on Sunday night. And I think this issue of trust and availability is one of the big pluses of the telemedical possibility. You don't have to go somewhere, you don't have to dress your child, you don't have to go out in the night. You can talk to somebody who's really specialized and understands your concern, at 10 in the night.
And last question, how long can this go? Because the eating school is limited to 2 weeks in person. How do you range from, for example, I think some problems could be solved in a couple of weeks and others won't. How do we deal with that difference?
Well, the eating school program offers 1 week
Yes.
pre-contact, 2 weeks of eating school, and then 2 months of aftercare, where we check online, where we check the stability of the reach goal and see how the child adapts to its home environment, and whether it's possible to increase even the skills we are intending to do. And the net coaching basically is defined to a 3-month period. But if the parents, we usually are able to remove the tube, go down to 0 within the first month, nearly always, sometimes even within the first week. And then the time after is used for stabilization, for calming the parents that a child will not rocket with its weight immediately after the tube is out. It might take 2 or 3 weeks, and there's a kind of a dynamic, but mostly the whole tube weaning process is absolutely over within 2 to 3 months. If not, we have the option to prolong this period. We discuss it with the parents by the aftercare program, which is a monthly ticket. So, and we often say, well, why don't you try for 1 month to move on and give us an update at the end of the month, and then we can also start still an aftercare month. Yeah.
It allows both sides flexibilities. Welcome also to the people that weren't yet quite here when I did my first welcome, and sorry for the technical difficulties that we faced tonight. We will extend this meeting to as long as we need it. Now we've given a basic overview, and now we are ready for your questions. Thank you for sending some in, but we always prefer to have the questions of the people that are in the room with us. So if any one of you have a question, please just unmute and go ahead.
Yes, hello, good evening. I'm Leoda from Latvia. I had a question about the prices. This is the hardest one for us. This is the only obstacle why we aren't yet in Graz. Therefore, in case we assume to take these visits, we can also ask for some help, but we need to assume how much it would cost around.
You want to ask how much is the online program or the eating school?
Yes. The eating school, I know, yeah.
Yes. Hast du die Zahl im Kopf?
I don't have the number in my head, but it's about half. The online program is,
We'll check it. I do think you can see that online.
It says prices. Just a moment. Maybe Leide, I can tell you, Aaron is just looking it up. The price for
It's about around 6,500. Oder? Here, NetCode, yeah.
net coaching. In euro, 6,350. In US dollars, 6,850. And Leide, thanks for asking this question, because it is absolutely crucial for many families. The possibilities to get funding for this, if you can't pay it just from your own pocket, are more than we think. Many patients come with what is called nowadays crowdfunding, or the child has a diagnosis which is supported by certain communities and associations who just pay it. And in about 70–80%, we can convince the insurance, the health insurance of the child to take over. Because in our opinion, especially the tube is a neglected intervention of the hospitals. It's really the business of the hospitals, if they place a tube, to also take care of the tube management and the tube removal. And so we are kind of filling in for a lack of aftercare of hospitals. And I am absolutely convinced that this should, in all cases, be paid by the health insurance of the child. And also know that about in 5 months, the costs for tube feeding your child for 5 months more are already covered by the eating school. So it's absolutely stupid to kind of discuss about prices. If the insurance who pays the tube feed would understand that they will be able to stop tube feeding this child for the rest of its life, if they understood this and acknowledged this issue, I think the insurances can be convinced. And we are also prepared, Leide, to talk to your doctors and insurance people if it's really a question of understanding.
Okay, thank you. So in our case, In our case, it's so we don't have health insurance for children in our country. So because everything is covered by the state, so it's not. So it's a little bit different from many countries in Europe, and yeah, and actually that's it.
But if you have any further questions,
Yeah.
please feel free to book a free evaluation. There we're
Okay.
much more easily able
Yeah.
to focus on your individual
Okay.
and
Thank
also
you.
country-specific concerns. Thank you very much for your
Thank
question.
you. Thank you for
Thank
answers.
you. Who has further questions?
Hello,
Hello.
my name is Lucia, and I have a daughter, Emma. She's not on tube, but I would like to know how important it is to know the diagnosis before we start the program, because nobody actually diagnose the problem. They keep on, like, first it was aversion to food, now it's not, then it was because my daughter is a preemie. She was born very, very soon and with very small weight. So we have many issues that we are working on, not just the food. So that's why the online program scares me a bit, because we have to do many exercises all day. So I would like, I would
Great
have to
question.
be focused only on this, but I
Yes.
don't know if you can diagnose in the program as well, because we still don't know why she doesn't want to eat.
Yeah. Well, Lucy, I can't promise you that I will come out with a ICD code number for the diagnosis, because mostly it's more complex. For instance, in the case of your daughter, we have an extreme prematurity, a low birth weight, a phase where she was tube fed when her life started. The transition to non-tube happened, I would ask you that. And then we have sensory, motor, emotional, a whole variety. And we don't really care who gives this problem which name. We try to understand the complexity, which is, it's never one reason. It's never one reason. It's always a composition of different levels of skills, which all come together in the complexity of wanting food, understanding food, being able to see the food, wanting to have it, motivation, wanting to lick it, smell it, and really tasting is about step number 5 or 6. And then it comes, how does the food go down, and is the child able to swallow easily? And the only thing when we can't help a child, if it has a severe neurological swallow problem, that means it can't swallow water, and then we are hesitant. We might then ask you for additional examinations, but if we are sure that the swallow function is safe and the child is not at risk for any aspiration, we don't care which doctor or specialist has given which label. It's not important for us. It's more important to see the videos, to read the reports, and to hear your opinion. And yeah, if there are therapists involved in the life of your daughter, we might also get a report from them. But the actual diagnosis, many children have a hidden genetic disorder, which might be involved, but it doesn't really matter because we can't change it. And many children they find a genetic disorder, but it doesn't affect the eating at all. So it doesn't really help us to move on.
And here, what I want to add, and if you have further questions, Lucia, please ask those. I want to explain a little bit also to the other parents here why we work with diagnosis the way in which we do. And the reason really is our child-led approach. Your 2-year-old daughter, even though many things have said things about what she might have, if she could talk, she would not use a fancy medical term. She would say either my belly hurts, or I don't want to eat, or I can't eat, or I don't know how to. And in our therapeutic approach, it's so focused on the child that for them, the diagnosis is very unimportant. It's very important for the insurances. Sometimes it's important for the parents because they just want to know what's happening. I understand that. But for the child with the issue itself, the diagnosis is a label. And what we do though with diagnosis is either they have some physical aspect that we just need to focus on, much like issues with swallowing, etc. Or, for example, we have a lot of patients on the autism spectrum disorder, and there we already could assume that hypersensitivity plays a role. However, we do not work in saying, it's autistic, we don't need to know anything else, this is what you should do, because we don't work on model fits the diagnosis of the child. We need to just see, because every child that comes to us with this problem really is very, very individual, if that makes sense.
It makes sense, and it sounds great because I don't think that anyone can label the problem, and each person who sees that he thinks that he knows, but it's not true, and they don't respect my opinions because she doesn't show it to them in the moment when I want her to do so. So that's great that there's no diagnosis needed.
No, the only question also when you would come do the telemedical route is, I think the diagnosis matters most to the insurances. So when you face a question regarding insurances, they might need this. As far as you are concerned for the assessment, it's...
I write something which I think sounds fancy, and then
Okay.
they'll accept it.
Especially now with ARFID being an umbrella diagnosis. A lot of stuff fits into it, but then the question is, I can name you 10 different children and we can call them all ARFID. So then the question is really, how much does that contribute to understanding? But yeah, so much to that, Lucia. Does that answer your question?
Thank you. Yes, it does.
Perfect. Thank you very much. Any further questions, maybe? Or also, if other parents have similar situations or can understand or resonate with, for example, what Lucia has faced, then please also feel free to share if you feel like it. We're not the only ones who can answer here.
Hi, I'll ask a couple questions. I'm Amanda. I'm from America. My daughter has Down syndrome. I have no at any sense of what her intellectual ability is, right? Because she's only a year and a half. So we're still learning. But she's very engaged and very active. Is there any does that affect your projections in that 2 to 3 month time frame when you give someone, again, I know we just talked about diagnosis, but Down syndrome children typically are slightly delayed intellectually, so just curious if that has any effect on your timetable.
Is your little daughter, has she been put on a tube or not?
Oh yes, she's been on a tube since she was a month old.
And the tube was given because of a cardiac complication?
It's because she had a cleft in her throat, and so she was aspirating when she swallowed milk.
And has that been fixed?
It has been fixed. It was fixed at 6 weeks of age. No, I'm sorry, 4 or 5 months of age. But she had lost her natural swallow reflex by the time they fixed it. So she tries all kinds of food. We have lots of nice engagement with food, but she just is very dependent on the tube now. So.
Well, Amanda, thanks for asking this, because apart from extreme prematurity, Down syndrome is one of the most frequent comorbidities we have in the tube children. We know hundreds. And Down syndrome children are special in that they might be a little tiny bit more stubborn in meeting a change. They might need a tiny bit more time to kind of adjust to a change, But basically, every Down syndrome child prefers learning to eat on herself or himself than being tube fed. It's a kind of, they can't help that the world thinks, oh, the Down syndrome makes things complicated, and kind of then forgets about them and the tube because it's growing. So our experience is that basically, of course, their eating development, let's say at 12 months, is a tiny bit different from the eating development of a child without Down syndrome, but it doesn't affect the weaning. The being younger in eating development can be an absolute benefit because the complexity of the thinking and the emotional interference is less because they're a bit younger, so they kind of easier dive into food than a 2-year-old academically more interested child who will say, oh, I'm frightened, I don't know, and maybe mom will then do this and da 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 da. They're not so complicated. They just love food. And as soon as we do the tube reduction and monitor that daily, they really mostly kind of, they just dive into it and they love to get rid of their tube. It's not in no way it's a disadvantage.
I want to add a question on top of yours, Amanda, and that is the expected range of different foods for a child with Down syndrome also projecting different? Because the question comes from the fact that autistic children, they naturally often have a very smaller or reduced range of foods. Is this also something that you see with Down syndrome kids once they're weaned?
Not at all. But we mostly have children who are weaned from the tube onto brei,
Purees.
puree. They're mostly longer on puree food and are a little bit older and mostly after the wean that they go the next step to the solids. They love the puree food and also having possibly a bigger tongue. That's all no problem. And then they're mostly not highly selective. It's more the texture and they're very sensitive to stressed mums, and one has to be very good at kind of giving the child a safe environment and a happy time, and then it'll really indulge in the therapeutic approach we have, because we tell the parents,
Step back.
or organize a play picnic, step back, play with your child with the food, all that. They enjoy our approach.
I want to welcome even more people. Thank you for coming and sorry for the technical delays. Amanda, did that answer your question? You said you had a couple, maybe one more. But maybe just one of your list if you have a couple.
I think that mostly answered it.
That'll do.
I guess my other, comment, it was just that like right now she's like loves to interact with food and will try, bits of food, but she gets 100% of her nutrition via the tube. Is that typical for your kids?
Completely.
Starting
That's
the
what is
program?
called tube dependence. And before we don't really nearly drastically reduce the 100% to about 50, things will not change. It's an absolute nonsense to tell parents, wait another 1 or 2 years and your child will increase the oral intake, but we keep the tube feeds. That's nonsense.
And I think translated to layman terms, as long as you don't give the child a reason to step out its comfort zone, it has no reason. Like rationally, why would
It
I do
resonates.
that? Yeah.
Yeah. It's
Thank
just,
you
this
so
is
much for
easier.
your question.
Why do that? Yeah.
Exactly.
That
I don't have
completely.
to, I can now look at it and play with it. Why would I need to make my tongue dirty with this food? This is much easier. Thank you
Yes.
so much for your questions. Here I see one in the absolutely. I see from Annelien. Would you maybe just ask your question, Annelien? Then everybody can understand it better.
Yes, I heard you say it's nonsense to think that children will get off the tube when you adjust the food above the 50%, but is it for all the kids or is it only for Down syndrome kids?
No, I mean, I never ever have published in all my years of publication. I never offered like a formula, a mathematical formula by how many percent on which day, 1, 2, 3, you reduce how much, because this is very individually and has to be adjusted to where from the child starts. Because some children start the weaning at point 0. They have never had anything in their mouth except toothpaste and their own saliva. And some children, like for instance Amanda's child, is already familiar with tastes and even possibly has swallowed some of it. So we take this very serious. Where do we start from? And we start, of course, not mid drop to 50, but we take off a certain amount and then see how the child reacts. And since we are with you in a close contact, we adjust the tube reduction plan every single day to the child's intake, which is documented on what we call the intake protocol. So the parents tell us every day, like she had 5 times a small sip, or she had 6 times 3 milliliters, or 2 spoons, or whatever. This is a very individual plan. Each child gets its personal reduction plan. And we also have to sometimes interrupt the process. For instance, when we just now had a kid where the whole family suddenly fell ill with COVID. So we have to make a little adaptation and stop for a few days, and then we continue.
And Annelien, I find myself today in the translator role. Please correct me if I'm wrong, but I do think it is correct that you have to go down drastically because you need to be hungry to try food. And it's this feeling of hunger that for children that start their life basically on the tube, that the feeling needs to be learned. Like, what does it mean that the belly makes a sound? And so there, what some patients, we have one recently who says, I want to leave the tube because it makes me feel safe as a parent, but can we work on the eating development and the variety of foods?
First.
And that is difficult to attain because the motivator will be hunger, and hunger will only arise when the tube gets reduced to the amount it needs to be reduced. What we never do is just say no more tube, then we'll take it out and then we'll see what happens. So this reduction, especially also in taking care of the parents, is very step by step. And if everyone's on board, then once this sort of brave step needs to be taken, and then what parents often forget is there is possibility to go back also, especially when there's a medical concern, when it's with the nasal tube, etc. And yeah, does that answer your question, Annelien?
Yes.
Perfect.
Because yeah, we have a daughter. Maybe I should
Please.
tell a little bit about our situation. We have a daughter. She's 2 years old, and she was born with a complex medical problem. She has a edapsopteresa. I don't know how you say it in English. But she was on oxygen. Yeah, for like 5 months, the first 5 months of her life. So she never learned how to eat, but she swallows her saliva. So the doctors say she should be able to eat. But now she's 2 years old and she's still 100% tube fed. And she really likes food. I think in her head she thinks she eats, but she doesn't swallow it. So she plays with it, and
that's exactly the candidate.
She does the fun. She does the fun version of eating.
Yeah.
Plays with the food, and then she gets the food.
Yeah, and then she puts it.
Yeah.
Everywhere.
And she can skip the swallowing part if you want.
Yeah.
And right now that luxury is still provided to her. And once the tube is out, that isn't a viable way anymore. So that's why with the tube weaning, as much as most people's goal is to get the tube weaned, there is this hesitancy because both for the child and the parents, having had the tube took care of a lot of concerns and issues. And so really this leading on to away, being able to go away from the tube. That's also what my mother was describing as sort of this like getting to know each other period at the beginning of the telemedical treatment.
Okay. Yeah.
Lovely baby, Lucy.
Thank you. That was Emma.
Thank you for your question, Annelien. Once again, I'll say it. We will extend our meeting time a little bit today. Anybody that wants to
20
leave, everyone is more than welcome to leave whenever it's good for you. We showed up 15 minutes late, so we want to extend those additional 15, 20 minutes. Are there any further questions in the room? Deandra, I thought I saw your hand raise gently before.
Hello, I'm a Brazilian dietitian, and I heard you. I speak very bad English, but I understand better.
Perfect.
And thank you.
Do you have a question or no tonight?
No,
Thank
today.
you for coming. Perfect, no problem. Thank you. Any further questions?
Maybe I have one more. We talked about the insurance. Is it is it an option that is this arranged before entering the program, or is it during the program that we ask the insurance if it's covered, or
Yes.
how does it work?
So it works very individual. We have decided at a certain point, Annelien, that because we're working with a global community, that we are not, it's not part of our program as much to completely deal with the insurances. We will give any assistance, be that publications, be those diagnoses from a doctor, etc., etc. However, I say that so gingerly because I would love to say it's covered, but we can't guarantee that. And even in Germany, where we have the most experiences with different insurances, the same insurance with a similar case will one day say this and one day that. Usually it's done before because it is a question of how will this be paid. And a lot of times we also heard tonight, but people are struggling with this amount of money. And so for them to make the decision whether or not to purchase this will be discussed with the insurance. And unfortunately, there's another aspect with this that a lot of insurance will say we have this regional program for you, which I feel like we are allowed to say that at NoTube is not quite as good as ours. But there, a lot of families get slightly pressured to do this. And then we had families that were 3 times in all different, say, Dutch or German programs. And then they come to us because the 4th round, the insurance says, well, okay. But so it's tough to really say. One should definitely, most insurances that work with little children and especially also preemies or something like that, they must have heard from us from one or the other patient before.
I just want to add that, 6,000 euros sounds really a lot. You can buy a small car for that money. But if you look at it compared to what has been invested into most of these children in the time since they are born, it's like
I know.
it's
But
it's
the
very
issue, but the problem is the hospitals pay
Yes,
it and
yes.
nobody knows and
But
it
the
comes out the
problem is
pocket.
that in many countries, parents kind of get the feeling that everything they get is for free.
Yeah.
But it isn't for free. These a day in hospital costs, tons of money. Every operation costs tons of money. And here we are saving with we have to pay our employees. So it's I used to work in the hospital, and then the hospital turned down all patients who were not from Austria because they started saying, why should the Austrian taxpayer pay for patients coming from Holland or America? And so I think my experience has been that if you have an individual contact in your insurance, Mr. Smith is responsible for my little girl or boy, then one can start really explaining to Mr. Smith why this investment and this kind of last part of the treatment of the child really, really, really makes sense and is crucial for the whole child's further development. Because whether you go to kindergarten with a tube or without, it makes a huge difference. And some kindergartens even discriminate tube children and don't take them at all. And so I really, I've become a kind of advocate for normal oral development, because the consequences of not weaning a child are far further than just not having or not the tube. They're not invited to birthday parties. The parents are frightened that somebody might pull the tube. You know, it's really, it affects their whole personal childhood. And that's why we feel that it's a neglect of the hospitals, which has to be filled in. And the children deserve that the problem is solved.
And I want to ask one more question to this. Have we made the experience that the eating school is more paid because it's more of a classical, you go somewhere? Is the telemedical approach did you hear a lot from insurances saying, well, it's some online program, we don't know? No, that's not an issue anymore.
No,
Good.
that's not really an issue. And we have publications which show the result comparison. And for about 30 years, we've been way above 90% success rates. So when the insurances hear that, we do mostly convince them. And I advise you, if you're sent anywhere else, please ask the place where you're sent to, how many children do you wean per year? And if they say 2, they don't go there. An institution and a team needs experience. This is the crucial thing. Without really doing the job as much as a surgeon does a broken leg, which comes in every single day, you will not understand each child well enough. And we do about 120 tube weanings per year, and we have, you know,
you can answer the success rate, because Amanda dropped another question. Do we see a difference in the success rate when we compare the eating school or the telemedical approach?
Not really. Overall, not. You can go into our literature list and
we've asked this question in a paper.
We have 2 medical psychologists who are researchers, and they've written fantastic papers on the comparison hospital to eating school and eating school to online. We've compared both, and it's extremely similar, with the experience that I have become very skeptical of sending young children to hospitals, because the infection rate there is really dramatically high. And to give one of these children, additional to the problem it has, 6-week unnecessary stay for some 2 or 3 gut infections is just horrible.
Yeah.
So it's really important to know where you go and to read the protocols of other parents.
And Amanda, what I want to add to your question is, we wouldn't offer the telemedical approach if we wouldn't believe in it. And we only believe in it because our success rate is what it is. When we look at the cases where it doesn't quite work, that comes with our approach. We don't promise something, and B, success means such a hugely different thing for individual patients. For some, it's the next small step, and for others, the same small step seems like a huge step. So it's really so tough to compare. And what I would say there is such small factors that we can't really think of. Somebody gets sick on a journey to the eating school. There is some issues regarding schoolwork, and therefore the computer is associated with. So really those 3 to 7% that we're talking about in our rate that don't succeed the first time and this is no excuse for the program, but there are just reasons that are, in our experience, far beyond the difference of telemedical and eating school. And actually it allows people to enjoy, if you want to use the word, therapy from afar. And that has allowed a lot of people actually to change something and improve something there, then it has the opposite, yes.
And also, if we're talking about children of 2 and 3 years or children at 1.5 and Down syndrome, most children don't, or I think a successful tube wean of a young child should hardly be noticed by the child. It just, the child doesn't know that mama is typing in the computer and all that. The child just notices, I suddenly have a different feeling in my tummy, and its behavior changes.
And mom's behavior changes.
Mom's
Hopefully.
behavior also changes, the related mom. But if things go well, the tube is out and the child is eating. It's like after having had a cast, and the cast after broken leg is taken off. It'll take a while for the child to walk straight again, and the same on both legs, but then it walks again and the job is done. So I think this is very important, that telemedicine allows, I call it the undercover therapy. We are changing important things, but the child is in its own room with its own siblings, with its friends, has a picnic in the garden, and mommy is behaving a little in a new way. That's kind of the experience of the children.
We come to the last-ish question. Before I move on to those, Amanda, yours is answered.
Yeah, I think so. I guess my only question is for the telemedicine approach, can you talk a little bit about like what is the like commitment of the family to the telemedicine approach? Like, because if you're in school, right, like that's what you're doing all the time. Like,
Right.
would you say like for that month, like everybody should be just fully committed
all.
100%? Like, how does that work,
Well,
like logistically?
that's actually a huge difference, I would say, and my mother explained it more from a therapeutic sense. I'll explain the difference that I assume from a patient's perspective, and that is mainly time. Once you have a 3-month process that is every day, continuously, but in smaller increments, and when you come to Graz, you have a 2-week intense, in brackets, in your face program. You're very confronted from day one with everything that's different. Online, well, we're a little gentler in the process, one could say. And so in a little way, you stretch it out. And that also means how intense is it for everyone else? And when you come to eating school, we ask the whole family to come. So there everyone has to take off work, etc. And online, nobody has to do that.
And also the time, because you asked about the time, Amanda. I would say with 1 or 2, 5 to at most 10-minute sessions, mommy writes the report in the evening, fills in the intake. It's not more than 10 minutes, definitely not. And then she waits 24 hours or till the next morning, gets an answer.
Yeah.
And so the time everybody should keep their job and nobody has to change anything.
Yeah.
And that's the benefit for the child, because it can go to the kindergarten, it can go to the nursery, the daycare, the life should stay the same, but we're changing a little something.
And for older children, because I want to move to the question in the chat, because we also do, for example, anorectic children that are 10, 15 years, etc., older. And there, what I love also about the telemedical approach, that allows us to have a ticket for the child, the patient, and they talk to our therapists, the affected people, and then the parents on top of that.
Separately.
Yes, and this is not possible for a 2-year-old, but really allows us new ways for elder children, which leads me to Jennifer O'Shea's question. She asks, can you wean older children, 5-year-old? Yes, yes, we can. What is the oldest child?
A 91-year-old lady.
You've weaned?
Yes.
Nice.
She had a tongue cancer and she was put on the tube. And my second oldest, I think, was 85 after a stroke. You can wean every person who still has the ability of healthy, safe swallowing and who enjoys the experience of food. If somebody is unconscious, in coma, don't touch it. I will not. But it's not a matter of age. It only, for school children, like from maybe 5 to 15, the mind comes into the process. And many children have become so friends with their tube that it's like an organ of their body. And then it's quite a process to kind of give them so much security that they will dare not to use, especially with the little tummy buttons, that they can kind of imagine a life without it, because that's a loss. It's like it's giving something, and the children are sometimes frightened of that. So we take it very, very easy. And if the child wants to keep the tube and we don't use it, then it has the plastic there still, and then maybe 2 weeks later it'll say, I think I'm ready now to say bye-bye to my tube. But it becomes very complex the older the children get.
But I think, Jennifer, to your question, in our eyes, 5 years is not old.
Yeah.
Yeah. 5 year is
Fine.
5 year is on the older spectrum of early onset or just very, very young children. But old for us starts at around 10, 11 as far as children go, and 5 is perfectly fine. Hi.
Hi. Yeah, and so it doesn't matter if she's been on the tube now for 3 years, and it's just a nasal gastric tube. I literally place it and take it out every day. So that doesn't matter how long she's been on
No.
either.
Yeah,
Okay.
does she enjoy getting it every day?
She does. She is just now starting to. I have 3 autistic children. This is another one, but they all are so different. My older kid literally eats anything. He's a normal picky kid, and then she eats nothing. But she's now starting to like. I actually bought your publication and I read it. So we're doing the family food time. I'm letting her play in it, and for a while she wouldn't even touch it. Now she's touching it. Now she she'll feed me and she'll kind of play like she's going to eat it, touch it to her mouth or her chin, and then giggle and run away.
Yep.
So that's as far as we've come, and that's just recent. And she does swallow water, and I don't think her dentist and everything, they don't think there's anything wrong with her swallowing function. So I'm very interested in your telemedicine program. We're in America, so
Very good, very good. Wonderful that there are such nice developments.
Samantha would like.
Yes, Samantha, you have a question. No, you don't. Perfect. We misread the arm. Jennifer, did you were able to answer your question about the ages?
yes, thank you. I just wanted to make sure that there weren't any restrictions on age or anything like
Absolutely.
that for the telemedicine. She's going to be in full-time kindergarten this year too. And I know you work with whatever the program tells me to do, we work with the teachers and everything as well, and her therapists and all of that. That's excellent. Excellent.
Perfect. I think I want to maybe end with a question that I've heard, if I would do like a summary question, and that is the question of suitability for online. We go to a hospital and nobody asks the question of suitability and qualification. You sick, you good to go for the hospital. Online, for us, the approach is very similar as the eating school. What has surprised me even coming in this organization is how small the group of children are that are not qualified for our program. I think I want to have this maybe be the last question to my mother, is what specific issues can we not tube wean? Maybe even telemedically or in eating school. You've already said coma is one.
Yeah.
But I think you can do it on one hand. And that really is to all the question is, does my child, it's very unique it is, but over the 40 years of my mother doing it, there were so many unique children that there is a good foundation. So what are really non-suitable?
Well, I think parents have to be familiar with the tool of communication, which is our computer. I mean, we have to find, we have our program in 3 languages and we can wean in 4 languages, Italian, French, English, and German. But if you're now, for instance, a Chinese speaking or a Pakistani or whatever language in the world, which we can't, I become a little hesitant when we have to use Google Translate. And we actually recommend in languages which are outside of our capacity to involve an English-speaking assistant, which means that the family needs a relative or a friend or a student come by once a day to help communicate with us. I have at the moment a Turkish family. The child is after heart transplant and the mother doesn't read or write our language, and there we need external help. But basically, if you are familiar with computer and can express yourself if possible, in one of these 4 languages. There is practically no hesitation unless the child has a so severe neurological impairment that our therapists say we really think it should be a hands-on approach. There's some children, we had now one where a child which is blind and deaf and has a severe congenital syndrome. And we in the assessment really felt we need to see her, we need to feel her, we need to be there with her. It's a little girl of 2.5. And actually she got weaned, it went easy peasy. But in those cases, sometimes our team will sometimes be hesitant to encourage the online if they feel that the kind of impairment of the child is too severe. That would be really the only reason.
All right, that puts us to 21:21.
That's exactly an hour.
I think that's a good time for us to end. Once again, thank you for coming. Sorry for the delay and the technical issue. Everyone that was part of it, you will get a little webinar clip, just if you want to look at certain things further. And if you have individual questions, please do not hesitate to contact us individually. Maybe we can help you. Maybe we'll see you in the future. Have a wonderful evening, everyone.
Bye-bye.
Thank you.
Bye. Thank you.
Thank you. Bye.